do with the over meetings now. Welcome to this meeting of Inverclyde Integration Joint Board. The meeting will be held remotely, with the filmed and recorded, live and subsequent broadcasts available through the council website. The Integration Joint Board is a joint data controller of Inverclyde Council and the NHS Greater Glasgow Clyde under the General Data Protection Regulations and Data Protection Act of 2018. This meeting will be broadcast and recorded to fulfill our public task obligation to enable members of the public and other members of the public to observe the democratic process. Data collected in this remote meeting will be obtained in accordance with Council's public policy available through the Council website. Members of the Integration Joint Board are reminded they should follow the IJB's established meeting protocol, including the round use of chat facility and comments during the chat facility are visible to all participants in the meeting, which may also include members of the public who also receive invitations to our meeting. Thank you. Before I start, I just welcome two new members to the board, and that is Mrs. Karen Turner and Dr. Paul Ryan, who were appointed from together Glasgow Great Health Board, and I'm sure you enjoy your time down here in Inverclyde. So first agenda, agenda 2 is the minutes. Declaration of interest.
Chair, we have the following apologies for absence. An apology from Laura Moore, Chief Nurse Jonathan Hines, Chief Social Work Officer, and Margaret T, Service User Rep. We now move to a roll call. We're asking for declarations of interest. And the following members please indicate that they're present at the meeting either in person or remotely. Councillor Moran.
Present in chamber.
David Gould.
Present in chamber.
Councillor Quinn.
Present remotely.
Councillor Reynolds.
Present remotely.
Dr. Metcalf.
Present in chamber.
Karen Turner.
Present.
Dr. Ryan.
Present in chamber.
Kate Rocks. Present in chamber. Craig Given.
Present in chamber.
Dr. McDonald. Dr. Jones. Gemma Earley. Present in chamber. Diana McCrowan.
Present remotely.
Charlotte Elliott.
Present remotely.
Heather Davis.
Present in the chamber.
Stevie McLaughlin.
Present in the chamber.
Are there any declarations of interest?
Dr. McDonald indicated he's COVID. Okay. Members, with your permission, I intend to go to items 1 to 5. Item 6, I'm going to change 6 to item 15, which is a report from Mr. Stevenson on the primary care strategy implementation, which is item 15, which will now take at 6, if that's all right, everyone. Thank you for that. So item 2 is the minutes of the Inverclyde Joint Board on the 25th of June. Members had a look at the minutes. Is anyone got anything they'd like to bring up? So we agree that minute. Agenda item number 3 is the Inverclyde Integration Joint Board NHA voting membership update. Okay.
Thank you, Chair. The purpose of this report is to ask the IJB to make a number of changes to its voting membership arrangements, all set out in the report, namely the appointment of Dr. Paul Ryan and Karen Turner as NHS board voting members to replace Alan Kevin and Cameron Burns. The report also seeks agreement to the appointment of Dr. Becky Metcalf as an NHS board voting member to the IJB Audit Committee. To note that Jackie McIntyre is the new named proxy member for the company carers representative voting member. The IGMB should also note that Councillor Martin McCluskey has at last week resigned as an elected member of Inverclyde Council and so is no longer a member of the IGMB. Further report on how this vacancy will be filled will follow to a later meeting of the IGMB. That's any questions.
Are we ready to change? Okay. Item number 4 is the financial monitoring report. Craig.
Thank you. In the previous convener, this is a standard finance paper to bring forward to the HIB. It covers a number of main areas. These are mainly our current 24-25 projected position, the current capital and the reserves position. Paper also highlights the current position of the transformation fund and the request to transfer the balance into a new innovation fund. Paper also gives an update on the progress against the savings targets to date. IGIB members should note all full paper on the progress to date will come forward to the November IGIB committee. Plus, we will set up a development session in October to focus on savings specifically and the progress made to date. Starting off, if we look at period 3, we're currently projecting an overspend of 0.495 million for the overall IGIB. Social care budget is projected to overspend by 216,000 and the health budget is projected to overspend by 279,000 at this moment. Obviously, by year end, we'll use reserves if required to bring this position back to break-even if that works out that way. So, looking at the detail, starting with looking at the social care side of the budget, children and families are projecting the 4 million overspend, mainly due to residential placements and child respites. Overspends at period 3. Jonathan and his team are currently doing a thorough service review in this area. At present, we're using the non-recurring pension monies to help smooth this overspend over the next few years while this review takes place. This is partially offset by underspends in our older persons, assessment and care management and mental health budgets. Secondly, looking at the health budget, mental health and patients projected to be overspent by 0.44 million and our prescribing is expected to be over by 851,000. This is mainly offset by vacancies across all main areas and savings groups currently underway, which is specifically looking at prescribing costs of health. The next section highlights the progress to date in the achievement of the savings programmes which we agreed as part of the 2-year budget back in March. As you can see in the report, we've already made good progress in the delivery of these savings. As mentioned earlier, a fuller report will be brought to IGIB in November and a development session to take place in October, which will give more details on that. Section 7 shows our overall earmarked reserves and it shows we started the year with 19.287 million and we expect to finish the year with 12.696 based on the current projections. Section 9 highlights the uncommitted funding remaining in the transformation fund and requesting that our reallocates to the new innovation fund. Capital. Section 10 shows the current capital position. At this point, we're not showing any significant spend to date, but this is likely to be incurred towards the end of this year and more so in next year, especially with the bigger projects such as the community capital project, the community hub capital project. As always, appreciate there's a lot in this report, but as always, happy to take any questions anyone may have.
Thank you, Craig. Any questions? David, and then
I think apologies, Mr. Chair.
Right.
Apologies.
I should have said to see if you want to talk, could you press the red light comes on, like an indication of what people. So who's first? So Paul, you go.
Thanks for that report. Yeah, you talk about your reserves slipping down a bit. What percentage of your budget is the reserve sitting at now? Do you know offhand?
It's for the reserves. Probably 5% in total.
That's healthy. Yeah, that's quite healthy. That's fine. Thank you.
Right, David.
Thank you, Chair. Thank you, Paul. I'd just like to say, first of all, I commend the savings update at 0.6. That's a considerable achievement so early in the year to get almost 1.9 million out of 2.6. So that's a really good piece of work by everyone involved. There's an awful lot of activity in the savings area, so that's a really good piece of work. In terms of children and families' client commitments, I was just wondering if you could perhaps have a little bit of explanation of why the likes of external residential placements, why we're having to spend additional funds to the tune of 2.3 million on that. What's driving that increase in demand?
Chair, if you don't mind, I'll take it and saying that Jonathan isn't here today and is on the way. So a combination of factors that some of these children are the legacy children that are taken in from COVID, where the level of risk was considered substantial. And when you take children in and they don't go home quickly, you reduce the capacity for parents actually to kind of manage some of the risks on their time. And the other thing is that we've seen a significant level of harm to children that has been established, and this is the issue nationally, so we're not an outsider in any of this. We also seen coming out of COVID that many of our foster carers, not many, some foster carers resigned at that time, and we've seen that our external residential placements are very, very expensive, upwards of to about £800,000 a year per child. And we've seen a level of children going through Inverclyde because we haven't been able to manage them with any of the existing resources at this time. In terms of some of the foster and adoption and kinship, including continuing care, Parliament brought in continuing care legislation and the biggest part was funded, but not funded in its totality. So young people have the right to stay in residential accommodation, and we have got a considerable number of them over the age of 18 that are in continuing care that we're working with to ensure that they get the best possible outcomes within the community. But the most outstanding issue is the level of harm that continues to be prevalent for children, and the current activity in this area is significantly high.
Could I perhaps just have a follow-up question? Do we know why the level of harm is increasing? Do we know what the driving factors are for that?
Yeah, a lot of abuse. I can't give you the detail.
No, absolutely.
Certainly a lot of issues around young people out with parental control, sexual abuse is increased quite significantly, particularly online activity, culminating from but that's across the board nationally. Our biggest challenges are teenagers who are presenting as having significant risk, and we're looking at other ways that we can support them. I suppose these are the main issues, but all the features of child protection, you can see that actually that we're exhausting the child protection register at times has its limits about providing that level of support, and when children are at that level of risk, we've got no choice than the staff duty to bring them into our care.
Thank you, Katie. Thank you, Chair.
I don't see no wrong. I think it's one that we do acknowledge that we look at. Diane, sorry.
Hello, under section 5.2, you say you've got vacancies in financial planning amounting to 333,000. That surely can't be right, is it?
It's probably just like minutes, that's a contingency reserve, so I can change that.
All right, Diane.
Yes, thanks.
As I said, I think it's important that we do acknowledge we've had significant inroads into our savings programme. the same token, we do remember going forward that, you know, the financial strategy, you can't all put reserves because sooner or later we're going to run out of reserves. And the fact that we thought we had a bit of a windfall this year, we know how to use it. And I'll talk about the debt reduction and employee superannuation costs. We spread a substantial sum of money, we never used it to offset the children and families deficit. So I think going forward, it's a good report, but I think we really keep our eye on everything to make sure that we start, if we can make the efficiencies, and we have to do it because using reserves as a strategy only won't work for so long, and you go there and run less. So we officers understand that, but I think we should emphasise that we do keep our eye on things, you know. Anyone else? Is that a legacy? Diane, is that a legacy hand you got?
Yes, sorry.
Okay. Thank you. Number 5 on the agenda is the role in action. Craig?
Thank you for coming. As is usual case for the HLB, this is all action list highlights from the reports from the main work that takes place during the year and over the next year ahead. It's fairly self-explanatory in terms of what we're looking at, but as always, I'm more than happy to put any comments, questions anyone might have.
Anybody got a question on the role in action? All right, thanks for that, Craig. Right, we're going to now take item 15 and have Mr. Alan Stevenson, who is no stranger to Inverclyde, who talk to this report. Alan?
Good afternoon, Chair. Can you hear me okay?
Yes, we can.
Thank you.
Yes,
Lovely
yeah.
to see everyone, though you're very small on the screen, so I can just about make people out, Chair. Thank you for giving us the opportunity to come to speak to you today about the primary care strategy and implementation. This is the last IJB visit now. We've been to all 6 and we're very pleased that, to have had the primary care strategy signed off at the board in late April. We've also now had the implementation plan signed off by the Moving Forward Together group and CMT, so very happy to say the work's underway now in relation to the workstream activity to actually take forward the implementation plan. Primary care is vital to the health and social care system. We have a budget of around 261 million in GGC, so it's not an insignificant amount of money, and actually this is the first strategy that we've had in GGC. It's only the second strategy in Scotland in relation to primary care. It's been a massive undertaking in the last 2 years in relation to the amount of engagement work that we've taken forward, both with patients and within our own service. So really pleased that we've managed to get that signed off. There's been a number in terms of governance. The strategy has also been to the Moving Forward Together group, the FP&P, which is a policy and resources group, and as well as signed off by CMT. And we've also been to the Area Partnership Forum. So we've been through all the governance routes with the strategy. The strategy is here for information today. I suppose the important thing to say is we're now off and running. It's a 5-year strategy. In the first year, we've committed to completing our workforce plan to move forward with our e-health improvements and to look at better integration across the system, because one of the things that came out from all the engagement work we did with the strategy, Chair, was people finding it quite difficult to navigate the health and social care system, particularly after COVID. I think people have found it more complicated. So we have a whole range of engagement activity we'll be taking forward now and explaining a bit more about primary care across the primary care family and how we plan to take forward the improvement work. I think members of the NHS, non-exec members, may well have been through the strategy and implementation plan a number of times because of the number of groups that we've attended, but hopefully the information's helpful for you. It raises awareness, and we're working very closely with the local team in Inverclyde, with Dr. McDonald and Alan, and his team, along with Kate, just to make sure we're aligned to the strategic plan in Inverclyde as well. So very happy to be here and try and answer any questions. Apologies, a couple of the team are off on annual leave this week, so that's why you've only got myself. Thanks, Chair.
Thank you, Alan. Anybody, any questions? What do you see, Alan? You know, I did attend the engagement sessions you had. In fact, the day I did, so many people had 2 sessions. You know, and you know, a lot of people were given an opportunity to put their point of view across. And I have to say, you know, we fully understand the decision we came to. We weren't completely happy with it. But I do think if we never had that consultation, we might even get less of a service than we have at the moment. So thank you anyway. But as I say, we were disappointed because we never got what we wanted, but we could understand the situation we were in. But anyway, we probably get a bit more we would have got. And so thank you for that. Doctor.
Can I say, Alan, well, I've seen this paper before. I got to mention interest in a GP in a former life, so I quite welcome the strategy there. It's important that links in with what's happening locally, your primary care improvement plan and so on there. But it's important to go on. The next stage is the implementation. Can you just remind us how it's going to be monitored?
Absolutely, Chair. Through yourself, we will be subject to, we'll have a evaluation framework which will be taken forward with public health, and we will be appearing, will be expected to be back at FP&P at least twice next year around that. A programme board which I chair, and we'll be monitoring our progress through that, and we'll be putting forward reports to CMT on a regular basis. We'll also come back on a yearly basis to the HSCPs to give an update in relation to the progress that we're making across the work streams in relation to how that's, what impact that's having in Inverclyde.
Yeah, I think one of the problems we had was the lack of communications regarding patient transport, and I think that's something that hopefully people realise. They lift their phone now and they get the transport. You know, that was one thing that we certainly missing. So that itself is a step forward, because we found that at that meeting a lot of people just were knowing about the patient transport. So thank you. Right, Karen.
Thank you very much indeed. One of the really critical points of a primary care strategy is the waiting time and the service that people get when they're not very well from the GP. How well they're looked after, and whether or not they need to be in hospital. What we're trying to do is to minimise the number of occasions people have to become inpatients, because most people don't want to be an inpatient in hospital. How are you going to monitor that aspect of the primary care strategy to see whether we've been successful there or not?
Did you hear that, Al?
Yeah, Chair, sorry, just broke up, but I think I understand the question. We have, is through the primary care strategy, we have a interface meeting with acute colleagues, and at that meeting, the clinical directors attend that meeting, and we regularly look at the information that we have in relation to waiting times and how that's impacting. So that's a bi-monthly meeting at present, and that we will understand the impact that that particular part of the process is having on primary care, both from an acute perspective, but also for ourselves in primary care. And we have all the senior management team and leaders clinically at that meeting. So it's the best opportunity for us to work through the issues in relation to that interface work.
May I?
Yes,
thank you very much. That's very encouraging, because I think we know that the morbidity in Inverclyde is very high. I've been enjoying reading a lot of the background paper before becoming a member of the IJB. What's so important is that we see people early. We see people before they get really ill, and I guess that's the challenge for us, and it's how we can use all the new facets of the primary care strategy to make sure that we really get a grip on that, and that we will. So I mean, I hope that over the next few years, we'll be able to understand the data from our local hospitals to see whether we think people have been seen quickly and well enough in time, that they've had all the treatment for which there is an evidence base, and that we're beginning to see the outcomes that we would expect to see for them. So I will very much look forward to seeing how all of that data relating to waiting time, impact and outcomes comes together as we look at our performance reports. Thank you, Chair.
Thank you, Kelly. Thank you. Thank you. Roll you back.
Frozen.
Do we have any more questions on? No problem. Okay, thanks, Alan. Thanks so much for your time today. I know you're not.
Thanks, Chair.
Right. Thank you. Back onto the agenda now, and it's the HSP Service Manager for Homeless and Settlement. Alan, first.
Thank you, Chair. This paper was proposed outlines the need to integrate the functions of homelessness and asylum refugee settlement into a single management structure. As a consequence, a service manager code is required to be created to ensure that there is cohesion around the strategic planning, service delivery, and improved performance supports the independent and related activity within these service areas. What we've seen around the settlements of individuals who have traditionally come through our Youth to Scotland scheme is really quite an increase in activity. What started off originally as a kind of add-on role for a service manager, but quite a number of years ago around the Syrian Vulnerable Persons Resettlement Scheme and the Afghan Relocation Assistance Policy has more recently, unfortunately, increased with the very, very tragic circumstances in Ukraine, where the Scottish Government has supported individuals to come to communities in the UK, Scotland, and other parts of the UK, how the team has helped individuals temporarily relocate to Inverclyde and support them with not just their health needs, but housing needs, social needs. And we all have also seen quite a sizable expansion and activity around the work that the HSCP has been doing with the UK Home Office in terms of people coming to the UK to claim asylum. We know we have a local establishment which has numbers within that establishment have grown greatly over the last 2 years. So within the team, we've seen quite a complex position start to grow. The team is now meeting the Scottish Government, UK Home Office, OSLA, and also the UK Home Office's commissioned agents here in terms about where individuals are either located in a hotel waiting for a decision or have had a successful positive decision and then to the community of Inverclyde. Inverclyde has a long tradition of being a welcome community and support, and the team, as the HSCP, the team have worked very closely with statutory partners, Police Scotland, the Fire and Rescue Service of Scotland, but also our third sets of community partners in terms of supporting. This team is also, through this piece of work that's been done, it's been quite clear it's also interdependent of our homelessness service, which again has been going through a period of redesign, and we'll await an outcome from an independent reviewer to see where our next steps will go with that service. But that service itself is a fairly busy service that supports members of our community in terms of dealing with the immediacy of homelessness, but the longer actions of supporting folk into their own tenancies. We'll see from the paper the sort of numbers that are going through, and I'm glad to see that Inverclyde has seen a reduction in terms of the number, in terms of the case duration and also the efficiency that we're going through, but that doesn't take away from the complexities of what the team are facing in terms of the homelessness team, plus the redesign of their service and going forward. This activity has shown that coming together. These two services are independent of each other. One really requires the other one in terms of the support. So the recommendation to the NHI is to approve the creation of a new service manager for homeless and settlement schemes, which will bring together the really quite complex aspects in management of the homelessness and settlement functions into a single service as we take it forward to support the community. Thank you. Happy to take any questions.
David?
Thank you, Chair, and Alan, and thank you very much for this paper. I have to say that when I was reading it, I just circled down 3.4. That's a very impressive performance statistics in terms of, like, for example, outcome of assessment going down to 71 days versus a national average of 114. And that does not happen by accident. There's an awful lot of time and effort has gone into that. I guess from my perspective is, if we are achieving as we are in this area, what would be the case if we didn't actually recruit this person? Is that going to have this individual that role? Is that going to have then an adverse impact in terms of continuing to bring down the outcome times and the number of homelessness applications? What's it going to mean if we don't? I guess is my question.
Yeah, what we're seeing, and this is where the interrelationship between the two services comes. Obviously, we know nationally the work that's been done around the settlement around people who have come to the UK for various tragic reasons in some cases. Where people get a positive decision, we have literally 28 days to ensure that they're not the homelessness system and we're trying to secure a tenancy. We work very closely with mayors who have a lot of activity in the Inverclyde community about sourcing properties. But also, there is an issue there if somebody doesn't get a positive decision, likewise they potentially could present homeless. And we're seeing we link with our partners across Scotland in terms of taking some learning from other areas, maybe some of the bigger urban conurbations where this is more prevalent and historical issue. But what we're seeing is it generates a lot of activity for the team to make sure that we're getting it right. And also, as we know, homelessness can affect MD at any time for various reasons, and we want to make sure that we've got that cohesiveness amongst the services to maintain the positive direction that we're taking.
Sorry, Chair, can I do
Yes.
So, sorry, just to say that as the priorities, the homelessness service is subject to redesign, but to set the context to the IGP, this redesign is also not just required in terms of the model, is because we were spending significantly in this area. So the service manager's job will be to implement the redesign as well as trying to bring things up into line in the budget. So it is essential, well focusing on performance and on the empathy issues while we're signing. So we have a few teams operating that could actually be the one team to provide settlement in its broadest sense within Inverclyde, and we think there will be efficiencies that will come from this.
That's what I thought would be the case, but thank you for clarifying, Ricky. That's really helpful. And thank you, Alan.
Dr. Mecca.
Thank you. I think my thoughts were similarly around this, we're creating a new post in a time we're trying to save money where, so that was really helpful. And thank you both as well for answering my questions before today as well, because I think I wasn't entirely sure from when we have got, as David said, good outcomes, although I appreciate from previous meetings that this is an increasing pressure, perhaps that wasn't necessarily expected, so wasn't necessarily built into strategic plans. But at the minute, this level of role, in my understanding, is being done but absorbed into other people's roles and separately. And so this post is going to make it more cohesive, more strategic planning around this particular part of the service, and I suppose spend to save. Is that? That's my understanding. But okay, thank you. That's really helpful, actually. Thank you.
Yeah, I mean, Steve.
Yeah, thank you, Chair. I think from the housing sector would welcome this. The two things I like are clearly linked. The impact, that settlement can have on homelessness if you don't get it right. You could be, increasing the need for temporary accommodation. You could be extending the need for accommodation, and ultimately, It's about, you know, being able to understand the impact it has on the local housing, a supply of affordable housing. Particularly, you know, the demand that's coming from HSCP services, and putting the two, you know, putting the two roles together, I think it makes a lot of sense, and we would welcome this.
Okay. Anyone else? No? As I say, I welcome the report too, but I think it's important that we realise that they're not be competing with each other, but you're going to have, you know, people from Inverclyde that are homeless and New Scots and ones, so they'll all be the same accommodation. So I hope that they're not conflict there, you know, I hope that the manager can manage that. But I would really appreciate an updated report, this is maybe 6 months' time to see how it's working, because it's one of the things that I'd like to keep an eye on, quite honest with me.
So happy to do that, Chair, but actually I think you'll find that the report that comes to the IGB in November around the redesign, you'll see, I think it's very important that we wouldn't have normally put this, this was to be created before it, but we actually need someone to go in there and immediately start implementing the changes because of the budgetary issues that we have within homelessness. We haven't utilised our grant funding from the Scottish Government either, so we do expect, and we would need to create efficiencies in this team. It's not that we, you know, want to, it's because we have to. So it may well be happy to do that in 6 months' time, but just to say to you that the report in November will give you maybe the.
Well, that's fine. I'm always guiding to yourself. I just, you know, I like to keep my eye on things, you know, especially for putting a new manager into post there, you know, and it's a very sensitive area, and I like to keep my eye on things, if that's all right. Anyone else? Okay, so we agree with recommendation. Item 7 is the clinical and care governance final report, and Alan, you're going to talk to her?
Thank you, Chair. Yeah, this report provides a summary of the yearly activity of the clinical care, clinical and care governance group structure for 23-24, and the IGB members are asked to note the report. This report will be sent to Inverclyde, as all the also the care partnership are requested to provide an annual report covering the overview of the clinical care governance. Apologies, Hector, the team have done a lot of work in this report, and it's a really positive report, and I'm sure Hector would like to be today to share this with you. But what you'll see in the report is a flavour of the activity that's been going on over the last year across health and social care services in terms of governance. We recognise that we have a fairly healthy clinical care governance group, which also has subgroups which cover across mental health, alcohol, drug and recovery, and homelessness clinical care. We have the health and community care clinical care governance group, as well as our colleagues and children and families in terms of their care governance group. We also have the links that cover into the worldwide mental health governance group and the learning disability governance group. So we have a fair coverage across the governance system. You'll see that I'm quite happy to see that we're growing and developing our clinical care governance report. It's gone from maybe in the past being traditionally more weighted on the NHS health side, but picking up now on the social care side as well. And I think that dovetails quite nicely with the action plan that was discussed at the audit committee earlier in terms of the recent outcome and action plan from the inspection of adult services with a viewpoint of mental health services. The report goes into quite a lot of detail covering across where we're overlooking things such as the DATEXs, the NHS's incident reporting system, as well as looking across various inspections across some other regulatory services and feeding back on that. The area also, the report also covers some specific services in terms of work being done around some of the primary care services, as well as some of the services across social care, children and families. It discusses the work that's currently done within our local care homes. I think one of the lessons from the pandemic and COVID, we picked up on the very knowledgeable and insightful local data we had about care homes, but working with them in partnership to strengthen that relationship and also to work alongside our colleagues in the Care Home Collaborative, so that we have a very strong now governance and linking with our colleagues also commissioning and contracting about getting a real oversight on our local adult care homes and also our supporting living services. So again, the report mentions part of the work that's done there. I think one of the things probably bringing your attention to is, I think it's very important, is the work that we've done around care opinion, seeking opinion, real-time live opinion from members of our community and the experiences that they have kindly shared with us in terms of their experiences when they've been supported by our services. For care opinion, one of the real benefits is that real-time response. People get a response immediately back from a manager within the service and picking up on what members of our community are saying. But we recognise we've still got work to do in care opinion. We want to cover more services, and really we're quite keen working with our colleagues in planning and strategy to care opinion will be a real cornerstone, a real field for people's experiences and the outcomes when they've used one of our services. So really that's the clinical care governance report for this year, and the IDIB has been asked to vote it. Happy to take any questions.
Dr. Ryan.
Thanks. A bit unfair to land you with it in Hector's absence, but I noticed it's a full report. It's very good, actually. You take you had 6 significant adverse event reports. I think none of them breached the duty of candour threshold.
Sorry,
I think there's 6 significant adverse event reports. I take because this comes up at the Health Post Clinical Care Governance. I think none of them breach the threshold of the duty of candour reporting.
We'd have to get through them, Dr. Ryan,
yeah.
individually to give you that, but we can give you
Yeah,
that.
it's worthwhile noting it because there's a separate report. We've had a report.
To Mayor, who went out as part of a significant communication piece.
Right, okay. Yeah, it's worthwhile mentioning that because it has to be a separate report. Other things in the report though, your MAT standards, and I'm impressed, very impressive, your MAT standards 6 to 10 are online. That's very impressive with that there and the work done there. The other thing I was asking is, you talk about your significant events and the learning from them. How do you share that learning?
I mean, across the system, we would start with the team that's involved and cascade that across the system and also online. But Alan, would you want to say more?
Yeah, no, thank you. It's obviously very important that a lot of this is about people's experiences and we want to pick up on learning from them, but that learning needs to escape being shared across the teams. And what we've done in the past is, particularly sat down with the staff groups, taking the learning from either a local issue that we've looked at, or we also pick up in learning reviews from other areas and say, well, how can we take this into our own area, especially around our learning disability services. We've strong historically about that, but that is something in part of the governance we do. The learning is really important to us because that is how we develop and change services, and as it says in the tin, learn from the experience. So yeah,
thank you.
Karen.
Thanks very much. It's very interesting. I found it very interesting and very useful. In the section where you've got on people giving their feedback and then telling their stories, some of the groups, one can understand why it's difficult. And I'm thinking particularly about people who use the alcohol and drug service, the children and family nursing services and the homeless service. When their lives can be a bit turned upside down, what are your plans to try and help them, help us get the services as right as possible?
So I'll start with the easier one first, which is the children and families. Children and families usually is an easier one, but we actually have another engagement app which is called Mind No, that has, before that Viewpoint. So there's been a long-standing tradition in children's services, and whilst it says, why are we not hearing the stories from there, it's because that is brought through a different mechanism and a different app. So all our children have access to that app children also in Inverclyde have access to a variety of apps within their education family who we work very, very closely with. So that probably needs to be defined right down about what is the offer to children. I mean, in terms of adult mental health services and alcohol and drug services, yeah, so we're pushing that, and we're pushing to get that story out there. We have fantastic stories that we hear from our recovery community, so we're not using it to our best advantage. So we need to do a bit of work there, because if you ask any of our sector providers that are on the call or Charlene, that there's certainly the stories are there, we're just not making them in that way.
Thank you very much. If I may just ask a second one to Kate. Taking some of the other papers, and I can't remember what numbers they are, I'm afraid, but the number of people who were referred into drug and alcohol rehab, and the very small numbers who made it through to the end, the work that you're doing on prevention, you know, when you start to try and put all of this together, it's tricky, isn't it? And I guess if the ultimate aim is to prevent this in the first place, then how we try and piece all of this together to give us the clues along the way is helpful. So bringing together what children, their parents are telling us, bringing together things like how long it takes us to respond to worry about neglect of children, and the points that you were making earlier about teenagers, and then this focus on prevention, treatment and rehab, and how we get people to stay in there. You know all this much better than I, but your papers today have helped me realise the complexity of that whole system and the importance of looking at the whole thing together so that we can see where the whole in a bit is. I think that's my rather long-winded way of saying that, Kate, so apologies for that. As you see, I'm new to it.
No, and actually it's a very good point, and it'll be one that Scott will pick up as part of our strategic plan in terms of bringing together our outcomes framework, and where the voices of lived experience, whether it's children, right through to adults and older people, are fed through that system and what that learning looks like. The care opinion is only one part of a bigger spectrum of engagement tools that we use, and I think it might be maybe helpful within a wider discussion later on that we kind of reflect that, as opposed to just seeing it from that one single care opinion element. But there is other tools out there that we use to engage with people.
Integrated Joint Board, last note, this annual report, the clinical and care and governance of 2023-2024, and this report was sent to the NHS Greater Glasgow Pride. Everyone agree? Item number 8 is IJB Direction Plan Report.
Thank you, Chair. The purpose of this report is to present the IJB promoting the full annual report, the summary and the use of directions for the IJB. As detailed in the report, the IJB approved a revised directions policy and procedure in September 2020. The IJB Audit Committee, as part of its terms of reference, has a remit to maintain an overview of progress with the implementation of directions and to escalate any key delivery issues to the IJB. The IJB Audit Committee has so far been presented with regular update reports in March and September of each year. Paragraph 5 sets out the summary of the detailed directions issued over the year, and a copy of the directions was attached to Appendix 1. Completed and superseded directions from previous financial years have been removed from the law. As stated at paragraph 3.4, which provides only a summary of the directions issued, rather than providing comments on their content, etc. This report is for closing, but I'm happy to take any questions.
Thank you. Any questions? Okay, hold the report. Thank you, Bridget. Item 9 is the annual performance report. Scott?
Yeah, thank you very much, Chair. Yeah, so the first line support is in the annual performance report for the HSCP for the service year 2023-24. So I felt our legislative obligations, all HSCPs and IDBs must produce an annual performance report. And then publish those in an accessible format on our website and make them available to the Scottish Government. So I'm looking for approval from the IGB to publish this report and share with the Scottish Government. Keeping with the Scottish Government timelines, a draft version of the report was published on the IGB website at the end of July this year for IGB formal approval from the IGB for the full completed report. So those who have a chance to look at it, the report broadly structured into 5 key sections. So our section 1 is our introduction, which sets out the introduction to the report, our key strategic vision within HSCP, and also outlining some key demographic information what Inverclyde looks like today, and also sets out some of our local challenges that we have. Section 2 is our focus on our performance measures. So it sets out our recent performance information in relation to the national outcome national integration indicators, which includes the national health and wellbeing outcomes. It also provides an overview of updated data for the Ministerial Strategic Group and relevant information from the local government benchmarking framework, and it also provides against each of our 6 big actions, our local performance indicators as well. Section 3 looks at our what we call our improvement journey. So this is examples of positive developments that have taken place during the year in terms of service improvements and other positive achievements that have been achieved across the partnership across all service areas. Section 4 provides an update on the HSCP performance over the last year, showing the outcome prediction for 2023-24. And finally, our section 5 is a section on how we can engage effectively with local people through community engagement and through our locality approaches. So it highlights how effectively we are taking to listen to local people and using their voices as we endeavour to improve our local services. So I won't go through the report in any detail, but what I would like to highlight in terms of the national integration indicators, the national outcome indicators are only updated every 2 years, and the national health and care experience survey. So that was updated this year, so the information we have is the most up to date for those 9 national health and wellbeing outcomes. And just in terms of overview of performance there, we've improved our performance against 4 of those outcome indicators. We've performed better than the Scottish average against 6 of those measures, and we've compared favourably with all Scottish HSCPs for 7 of those indicators. Highlighted 2, but happy to take any questions.
Paul?
Thank you, Mike. Thank you. That's a very full report. Can I go back to something that David touched on earlier about child services? You say you've had no child protection people in the case in the register for the past 18 months, which is very good, and there's less people in care, but the number of referrals are increasing. How do you manage it all then?
I'll probably need to refer that to
Yeah, sorry.
Sorry, run that.
Basically, you're saying that you've had no new child on the child protection register in the last 18 months, which is very good. But
No, we've had children on the child protection register, but no re-registration. So sometimes re-registrations within on the child protection register means that perhaps the risk hasn't been reduced at the point we deregister. So you would not want children back on the register very quickly, because it's an indicator that you're actually not that your plan for the child wasn't robust enough.
You say you're getting more referrals? You're getting more referrals?
The referrals are much the same, they're just the complexity of them are much more acute.
Right. So how you manage it? So you also put a lot of work into this?
Yes, so we are part of a partnership with North Strathclyde, which is what was called the Bairnshouse Partnership, and it's the first in Scotland in terms of that trauma recovery and the interface for the 4 local authorities, the 2 police divisions, the Reporters Department and the NHS moving forward. And we're strengthening that across the services to ensure that we've got that interface at the IRD. So at the very initial referral discussion that we're doing that. So we're also putting, and we've put family and children first at the front door. So for children that don't require statutory services that aren't hitting that most significant threshold, we're, Children's First are working with the families through family group conferencing to create a family safety plan to ensure that we're not bringing them in unnecessarily into statutory services, because we bring, I believe, sometimes children in too quickly, and we don't build the capacity within the family to resolve the difficulties that they have through with the period intervention. But I'm happy for us to bring a report to the editor, because there's been obviously a flavour of curiosity around children's services about all the work that we're actually doing, to try and redesign alongside the work that we've done as a part of Inverclyde lead on the Bairns House development within our Pathfinder. And lead it through me as the chief officer. So for the four, we've been able to get a lot of pro-system learning for the four other HSAPs, one for local authority and the two for police division. So there's many kind of strands to some of the improvement work that we're trying to do. But at the point we're still having to remove children and bring them into care, so you can see from the trajectory that less children are staying and maintaining life, and that's to do with their own internal resources. So we're all part of the design is looking at what will grow in Scotland and police. So we're currently undertaking a fostering campaign across the system that includes registered workers, so nurses, ex-GPs that require to be, I want to be a prosecutor in Inverclyde, that we're doing that dedicated part to try and grow our own in-house services because of the demographics and age demographics of our foster.
Thank you, that's very helpful.
Okay, I don't know if you Dr. Becker.
Sorry, thank you. Sorry, just last minute there. I was just interested in, it's page 135, and the indications, given what we talked about the good progress in the MAT standards in the previous report, and obviously previous reports on high levels of drug-related deaths. I was looking at the number of people who started on MAT treatment, and it says it was down 65%, but that's wrong, is it, above? Just wanted to double check that.
Sorry, which one is it?
SPI 5.2, and it says the difference previous year is minus 65% on people who started MAT treatment.
But the trajectory is up, so I think that's probably.
So that's just okay, fine, thank you.
Yeah.
So it's okay.
It's 5.2. It says minus 65, but the trajectory is staying up.
Okay, so that's thank you. Thank you.
No, that's probably a thing for it.
Yeah,
that's
Brilliant, thank you.
I just get maybe one observation. Sandra, you know the dental practice, you know, 1 hour practice just hold it up, goes down to 400 people without a dentist. One dentist is left as well, and I'm left in the same position. Is there any plans afoot to contact these people, tell them how they can get help to get a dentist? Because with a big demand, you know, for it, and I know there's some going to Glasgow to the dental clinic stuff. Is there any relation we can contact people and let know this is a route to treatment? Alan?
Yeah, thanks, Jerry. Yeah, I'm aware of the should be highlighted there. It's unfortunately it's not even Inverclyde. We certainly work with colleagues in the directorate to ensure that you know, where folk, where members of the community are seeking emergency treatment, and we make that accessible as possible. But we're also looking at putting more information out there in terms of how to access the emergency practice. If not locally, we would be treatment we take it, but it's something we're still working close to our colleagues in the director.
Yeah, one of our constituents contacted me. Her dentist in Bishop Briggs. She moved down from Glasgow about 5 years ago. But she kept going down to see the best decisions ever made because she still will get one down the other side. When that one closing the way it did, it's all people in the scrap heap, basically, and one dentist as well. So I just wondered if we were there in place where we can signpost them to people.
Again, it's an HSCP where somebody's having difficulty accessing it, you can pass the details on to the help direct, see where the next available area that could perhaps take a registration on. We're also working to try and ensure that we can work with independent contractors to see what the future lies locally. That's something we can consider to take up.
I know. I mean, the ones that will not get NHS anyway. There's always people there who may miss out, I think, because they're chance. We're at the top of it, and cycle to get treatment, that's fair enough.
Thank you.
Karen.
Thank you, and thank you for a very, very comprehensive report. Just looking ahead to how much easier it would be, I think, for us if I'm looking now at the section on the mental health strategy implementation on page 139, and I'm looking then further ahead to page 207 on the outcome strategy to 206, beg your pardon. So there's what we're wanting, quite obviously, is for people to be recognise that they need service, in this case it PAMS, but it could be anything really, within the remit within our remit, of course, and that they don't wait longer than they should, that when they get in, they have a proper diagnosis and the right treatment. So both of those things cannot be assumed. We will have to make sure that that's really, really right. And then that they do get, then I would have got 2.1 on page 206. I wouldn't just be looking to see that that there's the right increase in the number who report their mental health has improved, but I would want to see that they're back in school, for example. So it's how we bring together, what's our aim here? Our aim is to support the people of Inverclyde with as normal a life as possible, isn't it? So it's about children in nursery when they should be, parents supported to be at work, children in school, or children at college. And so that it's a big ask. I used to write reports like this. This is why it's very easy for me to sit here and talk in this way, because I know how tricky it is. But what we were trying to do was to see how we could bring together these bits of information for us, even just on an early point to start with, so that we have chance to, when we're having to make decisions about whether something grows or is reduced or where we put our priorities, we're better able to see that sort of total complexity. I really don't underestimate how difficult it is to get there, but it would be great if we could start with sort of 1 or 2. I'm similarly looking at the number of children who are overweight from the very helpful list on, you'll regret for being so much notice through the papers too, on page 187. It would be good to know how well the weight loss schemes work. You know, do we put something in practice, does it work? If not, do we try and play it again? Just because something's invented in Leeds, Henry and Works pharmacy there, doesn't mean it'll work well here. You know, it might. We might have our own. A little bit of, we did this and it works, so we're rolling it all around would be grand in the future reports.
Can I come in here, Karen, because there's quite complicated planning landscape. So this is a strategic plan for the HSAP,
right.
But running alongside this is the children's strategic plan, which is a multi-agency partnership plan. Okay, so the HSAP aren't the chair of that plan, but we do take data from that and we give them data, but there will be probably we'll have to look at the information governance systems about collecting the data, if that's even possible, because we rely on CMIS to give us information, which is an education system, and we don't collect that data. So it's wonderful if we could get that agreed across the board. And we've got 6 education authorities within the GTC, so it's very complex. But I'll remit this back to the Children's Services Planning Group as an observation to Scott, who supports them, that this was an observation from the HSAP to see if we could get that level of data for us in terms of the outcomes my initial reactions to say that that will be a bit of a challenge. I found we've got difficulties joining up 2 systems instead of 3, but we would be happy to have that conversation.
If I may, I mean, the last thing I'm wanting to do is impose even greater burdens on the way people work. And I guess I'm just trying to see if there's a way that others would share enthusiasm to do something a bit differently, but then not to do something else as well. So I think if we introduce new things, we should try and stop doing something else. That would be my aim. So it would be wonderful if you could have a think about it, but let's not get lots of people starting to do things if it's going to be unworkable, Kate.
No, I'm happy to do that.
Thank you.
Sorry, thanks once again to Scott and Kate, the officers, for use of support. The ITB notes the 2023-24 annual performance report and approves for submission to the Scottish Government and publication of Inverclyde HSCP bill. Okay, everyone happy now? Item 10 is the strategic planning partnership outcome. Scott.
Thank you very much. It's just as well, the performance policy against it. That would be the last time you supported against the previous strategic plan. The big actions, future and performance reports will be against the new plan and the strategic priorities were identified and these. So yes, we've just given the strategic outcomes framework being linked to the new strategic partnership plan we have. So we agreed our strategic partnership plan, I think it was at the May IGP, and that's now the key strategic driver for the HSCP Integration Joint Board. And within that, we identified the 4 strategic priorities to provide early health intervention, improve support for mental health, wellbeing and recovery, support inclusive, safe and resilient communities, and strengthen support to families and carers. And against each of those strategic priorities, we identified that a series of deliverable actions, and each of those actions had identified that a desired outcome. So since that publication, we've been working, in fact, we've engaged with our service areas, each of our service areas, and developed workshops for new outcomes framework. We've been focusing on those desired outcomes and identifying what are the key measures and the key indicators we can use to evidence the impact of the strategic plan going forward. So we've now taken that bit of work and we're looking for endorsement and support from the IDB to continue this development work to basically establish a full outcomes framework that will support future reporting and get into future and performance reports. So effectively, how we look at a series of indicators and measures, and these will align to each of our strategic actions that will then feed up into identifying how we performed against each of our strategic priorities, and pulling all these together will identify how we start our strategic rhythm. So it gives us that sort of really stepped approach to our performance measurement going forward. The indicators that we've identified within the outcomes framework are really looking to establish the impact and what is the thinking of the services that we've been taking and the interventions that we've had with communities of local people. So really looking to have those 2 outcomes and measure the impact of the services as opposed to simply thinking outputs or counting demand measures. So we're really looking at what is the output measures we have here. So from pages 5 to the end, we basically set that out against the frameworks. We've identified all the outcome measures that we have, and again, we're linked that to the national health and wellbeing outcomes as well. So it's really just a big comment from Integration Joint Board on the approach, and hopefully have endorsement to further develop this, identifying data sources and future reporting model.
Thank you, Scott. Any questions from Mr. Stewart? Dr. Wright.
No, sorry again. No, it's just an impressive bit of work. There's quite a lot of work there. It's a lot. So there's 32, I think, actions you said. But there's quite a lot of work in that. Is it feasible?
Yes. So I've been through them with my laser that we can collect that data, and when we can, we're just going to start with, so when it says activity only, we'll start looking at baseline because these are an important measure that we move forward in it. So all of this is doable within that, and the 4 heads of service that are responsible for the areas will be chairing that strategic group and looking at the improvements within that area and the actions that are going to deliver these outcomes. It picks up from the previous point that we have, we want to look at impact, and we agreed that the strategic plan should have an outcome framework. So this is the outcome framework that will show, hopefully IGB assurance that we're meeting the 4 priorities and focus on it. And it's something that we can develop through time. It's iterative. And it may well be that as we might still see some of the data, we might not be doing that great in that area, that then allows us to look at it. So there has been a huge amount of work done since we got the strategic plan approved by May to get that delivered, but we already had put some kind of framework behind that strategic plan before we took it to the IGB, Dr. Ryan, because we had to make sure that we could actually deliver on this plan to begin with, because the danger is you can write a plan and then you can't show the evidence it's making any impact. So this is an impact plan, and we hope that to develop that approach, and this is the first of its kind for Inverclyde.
Thank you.
I've got Diane and then Charlene. Diane?
Do we have baseline figures? So, because nearly all the outcome measures are about a reduction or an increase or a percentage change or something. I just wondered if we had the original baseline or if we're coming into this kind of halfway through.
So yeah, so for quite a lot of years we'll have baseline information because we have that established data source, so we'll be able to pull that baseline information. But quite a lot of the other measures that we've identified are brand new, so we'll need to set that baseline as we go forward in that initial data collection.
And they will be outlined as activity at this stage because we haven't got that in place, but we will put it in place.
All right, Diane. Charlene?
Thanks, Chair. Thanks for this report, Scott. I know that one of my colleagues has had an opportunity to talk through some of those outcome measures with you. It was really just to recognise that being a partnership plan, that CVS Inverclyde would be really delighted to work with yourself and colleagues to really take some of the data that we get, that third sector organisations collect, and really enrich what measures you've got here, and complement some of those measures that are in place where maybe your data has limitations, particularly around some of those ones that are activity only. I think that's where the partnership would complement what you're already collecting. So just to offer that support. I assume that might be picked up though through your performance board. So yeah, thank you.
Dr. Metcalf.
Thank you. Sorry, just I suppose on that point. So this will be monitored through the performance board, which you're going to chair, and then will come back to us.
It's monitored through the strategic planning group. Okay, so a report will come from the subgroups of the 4 areas: early health, communities, mental health and recovery, and family support, children, families and carers. So each of the heads of service will be responsible. They will be responsible. They will feed into the strategic planning group, which meets on a 3-monthly basis, and then twice yearly we will report it to the. We agreed that we would report it to the IGB on a twice yearly basis, so that we can understand the trajectory. So that is the governance.
Great, thank you.
Charlie, is that a legacy hand?
It is, apologies.
Oh, thank you. Any more questions? Okay. Hold on. Oh, sorry, David.
No, that's okay, Chair. I was late putting up.
Thank you. Very sorry.
No, that's absolutely fine. At the last IGB, Chair, you spoke very powerfully about constituent who got help with budgeting and healthy life choices in terms of how to cook for a family as opposed to. So I'm just interested to know, in terms of the work that we do and the third sector do, in terms of basically giving people agency, in terms of that ability to actually look after families and feel confident they're able to do that. I'm wondering how we would capture that through the data here in terms of the outcomes. So I'm not quite sure, looking at this where I would see it if I could see it.
I think you're doing quite a bit of work with our CLD colleagues there. They're up at the Rockmount Hall, different places earlier, to put this stuff like, you know. So I don't know, maybe.
If it's something we capture or not, so.
Derek got, you know, there.
No.
Yeah, no, so absolutely, so it's probably something will be difficult to capture, but
Yes.
I think we envisage how the reports would go is basically the measures that we've identified will need aligned next to the action update. So whatever action update we get in terms of the activity that's undertaken, so we'll have that in a narrative format, so it won't be in a data set or anything like that, but we'll have that narrative that should be reported back when we collect that information. And I think it's so, Charlotte was saying if we get that further information, that activity from partners and further in the American sector, so it will become more of a narrative update than it will be as a data update.
That's very helpful. Thank you, Scott. Thank you, Chair.
So I think the point there will be, you know, sometimes, you know, just get back to the basics, and that's something, all the help we need, you know, to get yourself, you know, feel like cooking, bunch of stuff like that. And maybe if we fix that at that level, we'd see it later on. Well, thanks, Brian. Well, so I just recommend that the notice of content report endorse the proposed outcomes framework for further development of future. Agree to that one. So number 11 is the mental health strategic refresh public engagement. Kate.
So, sorry, I'm still in the previous discussion. So this report just updates you from the briefing paper that we brought out that City of Glasgow discussed around mental health strategy and that whole system. So this is about the public engagement process of that to undertake a period of public consultation to look at ensuring that what we work with the public, we get the views of the public, or public help us to design what that looks like. It's a co-produced bit of work, and the refresh is to include the no wrong door. So any appropriate referral for secondary mental health will not be sent back to primary care. More people will have the experience, will be involved in everything from total production. We've started to see great success in this area, that the new head of addictions and homelessness was interviewed by people with lived experience, and the outcomes were similar to that of the professional panel. Prevention will be better explained in addressing wellbeing, so that's more about the self-management plan involved, because we know that from our own data that people come into mental health services, they might be waiting for an appointment, but they don't stay and complete their treatment. So that is something that we want to address, and we need to hear from our own communities about what does that look like for Inverclyde. I think we've got our own views. Our focus on inequalities, particularly within Inverclyde, and to ensure that we have inequalities by this consultation process are not further marginalised, and most of all, it's about improved access for mental health and situational privacies, and more established points of access, and a clearer referral pathways, and I've already mentioned the self management. So you can see that in 3.5, that's where the engagement process is, and what the phase 1 looks like. And then phase 2, and it's actually in the next week or the next 3 weeks. If you're about, we'd love to see you, because we've got all these mental health strategy sessions. We're having our first one at Port Glasgow Town Hall. I will be attending most as the Chief Officer along the head of mental health, and then Proper Minds Community Centre in Europe. And then we're having an online public engagement session, so that allows other people to engage. So we're doing face-to-face and online. So if you want to get any questions, I'm happy to do it.
Thank you, David.
Thanks, Chair. I guess probably just probably a dark laddie question on my part, so please forgive me. In terms of people with mental health challenges, would it be fair to say that the likes of the upper court have a disproportionate level of challenge if we look at our demographics, to my understanding. So I'm wondering, in terms of Port Glasgow Town Hall, is that the right place to actually engage with the community? Will we get them there? Will we be physically able to get there? Because I know there's challenges simply just going to get food for the upper port area. So I'm wondering if we are hitting them in the right place and we can actually get the people.
I think we're confident that's all the best place.
Is that great? Fine, that's all I'm looking for.
In the upper port, there's no Wi-Fi access either, so we're a bit digitally poor in the upper port. So I think
I do know
the chair would be right.
I'll take that assurance then. Thank you.
Karen.
Thanks, there's obviously a lot of thought been put into the consultation. It looked very, very comprehensive. I'm going to say something about the strategy, and I appreciate, Kate, that you didn't write it, but I would like to say something about it. On my notice board at home, I've got a little note which reminds me that one in 3 people who access mental health services don't get access, only 1 in 3 get access to evidence-based treatment, whereas 98% of people who have cancer have access to evidence-based treatment. But in strategy, there's nothing about improving access to evidence-based treatment. And I think the people in Inverclyde, I think we owe it to them to make sure that the mental health services that they need have the highest possible level of evidence base.
Thank you, Karen. Kate?
I will give the head mental health areas and holiday back. Thank you, Karen.
I actually have a meeting with her coming up.
Okay, because of your interest.
Diane?
I noticed the staff are also to be consulted in the future, but there's no dates yet. And the last engagement group was cancelled. So given that this engagement's all meant to be finished and done with by October, I was just wondering if we could get some dates out, because they're obviously seeing these now being advertised in public during working hours for patients.
I'll get the dates out.
Did you hear that, Diane?
No.
Alright, okay, I did put my mic on for a change. I will get that the dates out. I think it's a good point, so we need to get it to time.
Thank you.
David, that?
Sorry, that is a legacy. Apologies, Chair.
No one else will recognise the notes for the report and the plan for a public engagement process. And if any of these can make along with it, you're very welcome to turn up before the town hall. Item 12 is the chief officer's report. Kate.
Okay, because it is quite a hefty agenda, you'll be pleased to hear that my report is a bit smaller than normal. So I'm just trying to find this. So it really looks at their delayed discharge, our reviews with work governance and insurance in Scotland connected to care. So we just provided a lot of detail around the delayed discharge and our current position across GGNC and nationally, so we can see that there's significant improvement and we continue to perform well both across GGNC and nationally too. So you can see that the delays as a percentage of referrals and how that we've done that reduction, and then our hospital stays and our hospital beds. So at times it does fluctuate, but I think our trajectory is in the right place, and what we've seen is a significant improvement around health, the relationships and the partnership working between health and community care and mental health, particularly around adult and Katrina's world. So they're working together for looking at people as opposed to just looking at the interface for the systems, and see that reduction, and that surely really helped. And that's within the context of reducing members of staff as well. But what has really helped is a redesign of home care into a social care service in terms of us no longer carrying 77 vacancies. And I think that's the last one we're in 14 vacancies. So that's brought in a lot of capacity in the system, and including us having a wider provider list as well. So there's real strength in the partnership working, and that we're working together as an HSEP. People at the centre, very consistent with their strategic plan, as opposed to working in our own silos at times, even within the organisation to get silos. So I would want to commend both health and community care and mental health for their really kind of cohesive work that's been undertaken. Do you want to say anything, Alan, here? Because it's your fault. I'm talking about it's not more about your one. Do you want to add anything in?
Yeah, thanks, Bruce. Yeah, thanks, Kate, for really encouraging work, because really none of us want to see anybody unnecessarily delayed in a hospital bed, because we know that's not the best place for them. And there's a whole team behind these figures, and obviously that individual is a figure as well. We average about 100. Sometimes we talk about delayed discharges, but I prefer to talk about discharges, because we are currently at the moment discharging on a monthly basis nearly 180 members of community back to their own community. So it's a fair amount of activity. But as Kate said, I'm pleased to say that the results of all the work that we collectively did with the IJB's support in terms of our care at home service, getting that right for our community is really paying us dividends, as well as how we coordinate our delays, a whole system approach. So I'll certainly pass on from the work from the IJB myself, Kate, to the team behind this. Thank you.
Okay, and I'll just pick up the reviews with work governance. So the care inspector is undertaking a national reviews with work governance and insurance until the end. So we've been notified, and it is a national review, and it's really to get a greater understanding of the role, remit and effectiveness of the current challenges facing social work services, and we will look at governance and assurance arrangements in each of the areas, and across the full range of social work duties, including adults, children and justice. We ourselves have identified that as being a particular area for improvement, and as a consequence, the IJB in June agreed the formation of the Chief Social Work Officer that will take up all of that responsibility as outlined in the statutory functions of social work, and it will not be an add-on. So we are actually well pleased to have these discussions with the care inspection, so that they're having the national survey is out, actually staff survey, and that's in terms of frontline social work staff and first-line managers. I mean, we're submitting our core documentation that can demonstrate our governance and assurance processes across an Inverclyde, and there will be structured interviews with the core staff, which are mainly qualified social workers, and will include myself in themed focus groups. So I understand they will not evaluate the performance of individual partnerships on this occasion, but they will develop a national report that will probably look at the strengths and areas for development moving forward. I suspect that's really important, bearing in mind that the national care national care services still being discussed, so this will no doubt feature in some of the discussions. So thank you for that. Any questions?
David?
I think Charlie might be first, Chair.
All right.
Sorry, do I have my hand raised? Did you say? No, I don't have a question on this. Apologies, Chair.
It's all right, Charlie. David, give him your Chair.
Sorry, you're right enough, Chair. I'll be back in my box. So thank you very much for this report, Alan. I have to say, just looking at the way discharge performance, to go down, echo your sentiments, to go down from 502 in February to 257 in June is a real credit to you and your team and what you're doing. The integrated approach, the collaborative working is clearly working really well. Do we have a sense of trajectory going forward? Do we think that may potentially rise again come December. Is that a possibility? And also, how do we share the learnings that we've got in terms of our work approach with the other IGIBs? Because I feel there's clearly a strong story to be told here that I think the other IGIBs could potentially benefit from. For our experience, I'm just wondering, is there an approach that we take to do that? Is there a formal approach we actually share our experience with them? They can perhaps replicate?
First of all, we know the cliche from the TV programme, winter is coming.
Yes.
And that will bring a challenge, there's no doubt about that. I think we're in a much better place now than when maybe we were previously, but I think it will be a case of that it's something that we review. It's not even daily, it's multiple times throughout the day to see what the activity is, what the pressure is on the acute system, working liaison closely with our colleagues in the acute. We meet quite regularly with them as well to try and face the challenge, but I think as we said earlier, we're in a much better position in terms of our availability of the support packages within the community that we do, and also the work we do with our local care homes. So I think we're in a good position, but there will be a challenge, and I would expect as we get into the winter months, and if we, as we've seen in previous years, if we have a particularly bad run in some of the flus or other viruses, how that impacts. And again, that links into the work we do around vaccinations, the importance about prevention work about vaccinations. So it's something that we'll monitor. In terms of the learning, we do very regularly meet with our colleagues in the other HSCPs across Glasgow and Clyde, and we also have a lovely meeting on a weekly basis. Kate will be aware of it as well, where we share practice across nationally and take lessons from other areas. And you can definitely see it's been quite an interesting learning format for us all to say that would work for us, or maybe that wouldn't work for us, and other folk come to us and say we're interested. So yes, it's a constant dialogue around how we face the challenge around ensuring that folk are not unnecessarily in that acute bed.
Excellent, thank you. And once again, really good work. And please feed that back to the team as well, because that's a really good news story. It's good to see. Because every single person, every single number is a person getting home. So that is great work.
Thank you.
Dr. Ryan.
Can I ask you something, Kate, something you mentioned about the social work governance? And how does that fit in with the National Care Service and the work of the Chief Social Work Officer? And have we fed back views on that?
I don't know.
Yeah.
I mean, it has been commissioned, and Care Inspectorate are usually commissioned by government to undertake these national reviews. Yes. So I would imagine that the findings will feed back into that consultation process if it's December, but dependent on the timeline for the bill. It's very confusing, but I suspect someone has wanted to see what the baseline is to begin with. We could make lots of assumptions. Well, I don't really understand it myself. I'll be honest with you, I think that we've got so much assurance going on with the Care Inspectorate at this moment in time that it's really hard to get on and do the operational. They do tell me that this is much like touch, and if you can see it, it's, to be fair, but I'm not sure. So we'll just have to wait and see where it goes.
I think you're not the only one that's confused. Thank you.
Anybody else? Thank you, Kate. Who's in the private second?